Give a minute for everybody to kind of filter in. Okay, welcome everyone. My name is Sarah Lachance, and I'm the Resource Center Director for Northern Ontario with the Huntington Society. It's my pleasure to introduce to you the two speakers for this session on family planning and genetic testing, Clare Gibbons and Susan Conacher. Clare Gibbons received a Master's of Science degree in genetic counseling from Sarah Lawrence College in 1996, then joined the genetics program at North York General Hospital in Toronto, where she currently works as the manager of clinical genetics. Throughout her career, she has participated in the care of a wide variety of genetics patients and has been a member of the North York General Hospital Huntington Disease Multidisciplinary Team for over 20 years. Clare is currently a research coordinator for a number of observational trials and clinical trials, including Enroll HD, Shield HD, and Connect HD. She has been an investigator in clinical research studies involving computerized cognitive rehab for people with HD and talking to children about their risk for HD. So thank you, Clare, for being with us today. I'm also honored to introduce Susan Conacher. Susan graduated from McGill University's genetic counseling program and has been a genetic counselor for over 30 years. After moving from Toronto to London in 2002, she took over the Predictive genetic counseling program for Huntington's disease at the London Health Sciences Centre. This has now expanded into predictive testing, predictive counseling for all adult neurodegenerative conditions. In addition, she is the cardiac genetic counselor for Southwestern Ontario. So Susan and Clare will be providing us with an informative discussion about the ways that genetic counseling can inform your decision-making. From genetic testing to family planning, genetic counselors offer a number of services that help you make informed decisions about your family and well-being. There will also be a question and answer period at the end, so be sure to enter your questions for Susan and Clare in the questions tab on the right-hand side of your screen. Welcome to you both. We are so lucky to have two speakers with so much experience and knowledge about Huntington's disease and genetic counseling with us today. And so I will pass the floor over to you two.
Thank you, Sarah. All right, I will get started. I'm going to talk about sort of the genetic counseling or genetic testing process and what's involved. And we don't have a huge amount of time, so it'll be a very short version. Back in 1993, we discovered the gene that causes Huntington's disease, and that allowed us to then offer predictive genetic testing. And Huntington's was the first disease that we were able to offer predictive genetic testing for. And we weren't even sure if we should do that. There was a lot of concern around, generally in medicine, people come in to see the physician when they have symptoms, and we do tests to find out what's wrong with them and hopefully make them better. But the idea of taking an asymptomatic, healthy individual and doing a blood test and telling them that they would have a disease in their future, we weren't sure if that was something we should be doing. And so the initial protocols were quite, they were very burdensome. It took over a year to get testing done. It involved a neurological assessment, a psychiatric assessment, multiple questionnaires, multiple genetic counseling appointments. And it was very paternalistic in many cases that the researchers might turn around and say, we don't think you're ready. We don't think you're a good candidate for this type of testing. And so over the years, we've evolved into a different process, but many centers still have similar processes. So some centers do involve a neurological assessment. Some centers still require that people have a psychiatric assessment. And other centers like ours we just don't have the resources. So we don't have a psychiatrist that's interested in being involved in our predictive testing program. Our neurologist, it's over a 2-year wait to see our movement disorder specialist. So it doesn't make sense to include those things as part of our protocol. So it does vary from clinic to clinic, but virtually all clinics will have multiple genetic counseling sessions. And that's just to make sure that people are getting the information that they need. And I think there's this huge misconception about genetic counseling, and maybe it stemmed from the way it was originally designed, or this protocol was originally designed, that to some extent, our role is to judge whether or not you should have testing or not. And that is entirely the opposite of what we're there for. We're there to provide you with as much information that we can, and that ultimately, if you do decide to go ahead and do testing, you won't regret that decision. And so really the process of genetic counseling is a combination of information gathering and information providing. And the important part for me for information gathering is finding out the family history. So some centers will send out a family history questionnaire by mail and have you complete it prior to your appointment. I like doing it in person because that's how I find out about what Huntington's means in your family. So if somebody answers the question, who has Huntington's in your family? And the answer is, well, we've just discovered my uncle in England has Huntington's. My dad doesn't want to get tested, but I'm interested in testing. That tells me that you actually don't know very much about Huntington's disease, and we're going to need to backfill a lot of that information for that person to help them make the right decision as to whether or not testing is appropriate for them. Versus the person who says, my mother has Huntington's and I'm her primary caregiver, that tells me you know more about Huntington's than I ever will. And the information that that person needs is going to be very different. They don't need me to tell them what Huntington's is. They need to talk more about why are they thinking about testing at this stage of their life. And that's an important next step when I'm doing my counseling, is to say, why now? Why have you come through the door now? And that's especially true if Huntington's has been in the family for many generations. There are any number of reasons why people suddenly decide that or not so much suddenly, it's rarely suddenly, but decide that they're ready for testing or want to think about testing. And in some cases, it's because people themselves or other family members think they might be showing early signs of Huntington's. And so it's important to understand those families as well. So in terms of information providing, what are we doing? Well, I start with what I call my genetics 101, and I'm going to do a very abbreviated version of that, just so we're all talking the same language. And then we really talk about what are the things that we want you to think about when you're trying to make this difficult decision about whether testing is right for you or not. So all of our genetic information is packaged on structures called chromosomes, and we have 46 chromosomes in 23 pairs, and they're paired because we've inherited half from our mom and half from our dad. And a chromosome is basically just a tightly wound ball of DNA. So if we unravel a chromosome, it has hundreds of different genes on it. And on the top part of chromosome number 4 is the gene for Huntington's. So we all have 2 copies of the gene for Huntington's, one we've inherited from our mom and one we've inherited from our dad. And our genes have a code that provides the instructions for building a specific protein. So in this case, the protein is Huntingtin, spelled T-I-N instead of T-O-N. And our genetic code is made up of these 4 letters, C-H-E-T. So our alphabet has 26 letters in it, but our genetic code actually only needs these 4. And hundreds of them appear in a sequence forming the gene. Every 3 letters in that code codes for the building block of a protein. And so when we look at the beginning of the code of the Huntington's gene, we see these 3 letters that get referred over, that occur over and over again, CAG, CAG, CAG. And that's the code for a specific building block to go into the protein at that stage of when it's being built. When somebody has Huntington's, they have an expansion of this code, and they have more CAG repeats than we usually see. And consequently, the protein that gets made is much larger because extra building blocks have been placed in, and that makes the protein abnormal. And that's what eventually leads to that person developing symptoms of Huntington's disease. So we know that people who have 40 or more of these repeats will develop Huntington's if they live long enough. So it's what we call 100% penetrating, meaning if you inherit this expansion, you will develop Huntington's. We know that people who have 26 or less of these repeats are in the normal range. So not only will they not develop Huntington's, they can't pass it on. There are people in this unstable range of between 27 and 35 repeats where especially if it's a male passing it on, because it's unstable, it may expand. And that's in families where we don't really see a family history of Huntington's, sometimes this is what accounts for it, that a grandparent may have had one of these unstable number of repeats, and when they passed it on to their child, it was in the expanded over 40 repeats, and that person did develop Huntington's. And there's also a range between 36 and 39 repeats where people tend to get Huntington's later in life, and the symptoms don't tend to be as severe as classic Huntington's. So the important thing to understand about the genetic testing is that it can only tell you if you have or haven't inherited the expanded version of the gene. We don't need to know the number of repeats that exist in your family in order to do genetic testing for somebody. But it really, when you do the testing, it either tells you you have the normal number of repeats or you have an expanded version. It can't tell you at what age you'll develop symptoms, what symptoms you might develop. Or how rapidly or slowly will the disease progress for you. So these types of factors vary from person to person, even within the same family, even when they have the same number of repeats. And that's because the rest of our genetics is different and our lifestyles are different. And those things contribute to when people become symptomatic or what symptoms that they may develop. So what are some of the things that we talk about when we're having our genetic counseling sessions? So and this is not really a comprehensive list so much as these are some of the important things that we try and touch on. It's important that people understand that when you do genetic testing, it doesn't just impact yourself, that because it's an inherited condition, your results potentially impact other family members. So there are certainly circumstances where a grandparent may have Huntington's. The father has decided he does not want to know his Huntington status, but his adult daughter has decided she does. And so we need to have complicated discussions around, you need to respect your father's decision not to know his Huntington status. We will still offer you the option of testing, but we need to be respectful of his decision. And so that by potentially sharing your results with him, you're giving him information that he may not want to have. And we need to be careful around some of those circumstances. There are some countries where the at-risk person, so in this case, it would be the father, has to be tested before they would test children. That's not true for us. And I'm not aware of any clinics in Canada that insist on that, but it is a complicated part of offering testing. We also need to talk about how does this impact relationships for people, not only family relationships, but your long-term partner. What does this look like in terms of this may change your retirement plans? What does this look like if you're a young person and you're not in a long-term relationship at this point in your life? When do you start bringing up information like I potentially am going to develop Huntington's at some point in my future. And what does that look like? For some people, they want to know that information and share it because they don't want to partner with anybody who's not going to be supportive of that. And for other people, they'd prefer not to know their status because they'd prefer to be able to say, I'm at risk for this, not necessarily that this will be my future. The two main areas that we discovered as a result of our original research when we first started offering Huntington's was employment discrimination and insurance discrimination. And we are forever grateful to the Huntington Society for creating the private members bill and being very instrumental in that bill passing that prevents insurance discrimination. So, it doesn't prevent insurance discrimination, but it prevents insurance companies from asking for genetic test results. They no longer can ask for that. And people in the past were afraid to do genetic testing because of the insurance discrimination. And so that no longer is an issue for us. Insurance discrimination still exists on the basis of family history, though, and it's very difficult to protect our families from that. So insurance companies often ask broad-based questions like, is there an inherited condition in your family? In some cases, they specifically ask about Huntington's because they know about it. We're not going to tell them about all the other genetic diseases they don't ask about. Employment discrimination is an important thing to consider as well. So we talk a lot in our counseling sessions about privacy versus secrecy. So secrecy is never necessarily a good thing, but privacy is an important part of this. People don't understand the concept of being gene positive versus having Huntington's. So the person in your family who has Huntington's has had that genetic mutation or change their entire life. But it wasn't until a neurologist or a psychiatrist first started to see signs or symptoms of that disease that they actually have that condition. And so it's really important that people understand the difference, that when you have genetic testing and you test positive for the mutation, it's not the same thing as getting a clinical diagnosis of Huntington's. And that's where things like employment discrimination come in. We don't encourage people to share this information with employers. They don't need to know this information. We don't want them passed over for promotions because their employer knows that this is in their future. We don't want their employer to potentially get them off the payroll because they're worried about long-term, if that person needs benefits, is that going to cost the employer money? So we talk a lot about who do you want to share this information with, like who are the important support people in your family that need to know this information and who really doesn't need to know it, including, people you work with and people, close friends, yes, but maybe associates less so. So that's an important part of it. I'm not going to talk about family planning because Claire's going to talk about that in more detail. I think over the years, we've also become very conscious of the fact that when we think we're giving good news and saying, you haven't inherited this. We're just assuming people will do cartwheels down the hall. And what we've come to realize is that the emotional impact of hearing what we assume is good news can be just as profound for people. There was a very good talk yesterday about survivor's guilt and how important it is to talk to people about how they're going to feel if they test negative and other family members potentially test positive. We also talk about the fact that sometimes people, depending on the stage of their life, they may have made decisions assuming that they were going to be positive, and they might have made different decisions if they had known at that point in their life that they were going to be negative. And we spend a fair bit of time now talking about research and treatment and the new optimism. So when we found the gene in 1993, we just assumed we'll figure out what causes this, we'll get a treatment. And we went into this black hole for 30 years where we just had no optimism. The option of genetic testing was strictly for information. But now I think, we're able to say to families, there's such optimism, and you'll hear it in talks at this conference, that we're moving in the right direction to specifically having treatments that target Huntington's. And again, this is not by any means a comprehensive list, but we're really looking at what are some of the people's reasons to test or not to test? So what do people think about when they're trying to make this decision? So currently there's no effective treatment or cure. And so people feel, well, why would I get tested? Because there isn't a medical advantage to knowing. And other people say, I don't want to know if it happens. If I develop symptoms, I'll deal with it then. But knowing about it ahead of time is not an option for me. I'm not interested. The inability to undo knowing that test result. So we talk a lot about that once we've given you your result, it's there. We can't take it back. And that's, again, where we talk about we don't want people to regret that decision because we can't take back that information. Denial is one of my favorite coping mechanisms, but a lot of people feel if they don't know their carrier status, then it's the same as not having Huntington's. And so they just don't want to deal with it. Common reasons why people choose to get tested are just ending the uncertainty. So they've been at 50-50 for a significant proportion of their life. And that is almost generating more anxiety for them than actually knowing that Huntington's is in their future. Family, career, financial, future care planning. The key word here is planning. So planners tend to often want to get tested because it's important that they have all their ducks in a row, that they know they're able to make those plans and that decision-making based on knowing their carrier status for Huntington's. And in some people, they come in to be tested because they're concerned that they may be symptomatic. So as people get older, we all lose our cognitive abilities. And when people are at risk for Huntington's, that becomes much worse. So you start losing the car keys. Is this the first sign of my Huntington's? And that becomes, again, it creates a lot of anxiety for people. So they just decide that now is the right time to be tested for Huntington's. The ability to participate in research has become a key thing. We're starting to see more people and younger people choosing to do predictive testing simply because there is the ability to potentially become involved with research. And also the fact that if we're getting close to a treatment, then getting treatment earlier as soon as somebody becomes symptomatic is always going to be more beneficial than waiting until somebody has become very symptomatic. So things to consider when you're deciding if testing is right to you. I always talk to people about the value of the information. So at some level, you value the information it's going to provide you. So whether it's positive or negative, there's something that will be important to you in terms of you moving forward. The age that somebody chooses to get tested is very important. Just because you can test doesn't mean you should test at that particular time. We have people who book testing on their 18th birthday because we won't test them before. That's not to say I haven't talked to some very mature 18-year-olds who are very able to articulate why they want to be tested. But often that is a discussion we have. What's the right age for you to be tested? Are you emotionally prepared for either answer that the testing will provide you with? We also talk about people being in a good headspace at the time. This is life-altering information, regardless of what the results are. It's life-altering. And so the timing of life events, so even though marriages or expecting babies are happy times, they're still stressful. And so it's important that you separate away from important events in your life when you're thinking about doing predictive testing. And so just thinking about how the results will impact you and impact decision-making for your future is an important part of considering if testing is the right decision for you. Our final appointment with families is usually the results appointment. That's not to say we wouldn't meet with them again. And we often do follow up to make sure that people have all the information and support they need after the results appointment. But the results appointment tends to be fairly swift. Even when we're good or bad news, people tend just to want to hear the information and then leave us and absorb it. It often takes months for the information. Again, regardless of what the results, I've heard people say it has taken them months before it actually sinks in as to what the result was. So that's sort of a brief overview of some of the things that we talk about in our genetic counseling sessions. And I'm going to turn it over to Claire now to talk about reproductive options.
Okay, thank you, Susan, for all that background. So I'm going to just talk a little bit about reproductive choice and family planning. So if we can have the next slide. So the important thing to think about here is that each individual will approach the decision about whether or not to have children and how that will look differently, and that we should really respect each person's decision. Certainly, even within family members, we can have people who have different opinions on what should happen as far as the children. So the important thing is just to respect everyone's own decision and just make sure that the person has the information and the facts that they need in order to make that informed decision. So even from a very individual basis, there can be different factors that influence the decision. So one of them is whether or not the person knows their Huntington's disease genetic status. So a person who is at risk, so hasn't had testing, has a 25% chance to have a child with HD, whereas someone who's gone through the genetic testing and knows that they've inherited the expansion has a 50% chance to have a child with HD. So as you can see, even with looking at those numbers, that could influence a person's perception on what the next step should be and the risk for having a child with HD. Also, whether or not the potential parent is a man versus a woman, because as Susan had mentioned, that when the CAG repeats are passed from a man, they're more unstable. And when they're unstable, there's a greater chance for them to expand. And there is a trend, that the larger the number of repeats, the earlier the age of onset. So that a man could have a child that has symptoms at a much earlier age than he presented with symptoms, and even to the extent where it could present under 18 and be juvenile Huntington's. It's not in the majority of the cases when Huntington is passed from a man that there would be juvenile Huntington's, but certainly it is a much greater chance when it is a man versus a woman who's passing on the gene. And then the person may also have to consider kind of when their own health and when they might start to show symptoms, or they may already be symptomatic, and be thinking about how that might impact on being a parent. So these are all things that could be factors in the person's decision. So if we can go to the next slide. So just to be thorough, we'll go through all of the possible options that people may choose. So one is just to go ahead and have children and not think about Huntington's and not factor that in, or decide not to include that in part of the process. And certainly that is a fairly common choice that people make. So it's not unusual to make that choice. Some people will choose not to have children because of their family history of Huntington's. And then other people may choose not to have biological children. So in that way, avoiding the chance of passing on Huntington's by an adoption or using an egg or sperm donor. And next slide, please. So for those that are thinking about doing some testing in order to have biological children but avoid the possibility of Huntington's disease, one option is to do prenatal testing. So prenatal testing would be done in two different ways. One is through chorionic villus sampling, or CVS for short, and that process has a small chance for miscarriage, but it is able to very accurately test for the Huntington's gene expansion, as well as test for chromosome abnormalities. Amniocentesis also has a small risk for miscarriage and can accurately test for Huntington's disease and chromosome abnormalities. The main difference between these two tests is when they are done. So CVS is done around 12 to 13 weeks of pregnancy, whereas amnio is done 16 plus. There is a slight difference, as you can see, in the risk of miscarriage. It is a small difference. For both procedures, it is considered a small chance for miscarriage. So compared to the chance of finding Huntington's, which is 50%, you can see that even though I'm sure it is something that gets factored in, the difference between the two tests is quite small. The advantage of CVS is you can do it a month earlier than the amniocentesis. And so when trying to know what the next step, so the idea of doing prenatal testing would be that if it was found that the fetus had inherited Huntington disease, then that person would stop the pregnancy. And so stopping a pregnancy earlier is generally preferred from the patient perspective than later. So that's why CVS tends to be the procedure that is chosen when doing prenatal testing. But amnio is also a possibility. So next slide, please. So the other option for someone who wants to ensure that their child didn't inherit Huntington's, but doesn't want to go through the prenatal testing and having to face the decision around stopping an affected pregnancy is the PreImplantation genetic testing, or PGT. -M is the new term that they use for this testing. If you go back a few years, they would have been using the term pre-implantation genetic diagnosis, or PGD. They're basically the same thing. It's just the new kind of description that we use to be more specific when talking about the type of testing that's done for HD. So they now call it PGT-M to be specific. And with this procedure, the couple would go through the IVF process. That means the woman would be given medication to cause her to produce many eggs in one cycle. Those eggs would be removed from the ovary. And in the laboratory, the egg and the sperm would be put together to create embryos. The embryos would then be tested for Huntington's. And the embryos that did not inherit Huntington's disease would be transferred to the woman's uterus. And hopefully they would implant and become a viable pregnancy. A few things to know about the issues around PGT is that there is a cost involved. So there is a cost for the IVF process and also a cost for the genetic testing. So there is an estimate that the testing would cost between $25,000 and $30,000 per cycle. Each province has different assistance for the IVF process. So I would encourage each person to check with their province how much of this would be covered. But it is certainly not, in many provinces, not fully covered. Also, private insurance, if an individual has that, may cover some of the cost of the medications that are involved in the IVF process. So it is important to know there's a cost, but that it could be variable within the provinces and individuals, depending on their insurance. The other thing to keep in mind is that it's not that going through one cycle of PGT would guarantee a pregnancy. It's estimated that about 30 to 40% of the cycles result in a viable pregnancy. Now, there could be other factors that could influence whether or not the success rate of the IVF cycle. So if a woman has other fertility issues, that would potentially decrease the success rate. Also, as we get older, as women, the chance for chromosome abnormalities go up, and that will also affect the number of viable embryos at the end of the IVF cycle. So the important thing to keep in mind is that if a couple are going through the PGT process, to know that they may have to do multiple cycles in order to have a successful pregnancy. Also, they would need blood samples from the couple and other relatives. So generally, they would need blood samples from the woman and the man, and then the affected parent. So whichever one of the parents that has HD in the next generation up, they would usually need that blood sample as well. If that parent isn't available, there is ways to use other relatives' blood samples in order to help the laboratory develop the genetic test that's necessary for the PGT process. The reason for that is that they're not actually testing the CAG repeats in the embryos. They're doing it through a slightly different process, and that is why they would need the blood samples from the couple as well as the other relatives with potentially the other relatives with HD. Next slide, please. The non-disclosure. So this question comes up a lot. This would be for the individuals that are at 25% risk. So they know that they have a parent with HD, but they didn't want to know their HD status. So for the prenatal option, they again would need blood samples from a number of different people in the family. It's also not easy to find a laboratory doing this type of testing. And so if someone is thinking of this option, they really need to get in touch with a genetics clinic in advance and go through to see if this is a possibility before they get pregnant. It is not something that is going to be, from a timing point of view, possible once the person gets pregnant, because there won't be time to develop the test and go forward. For the PGT option, it is possible. It is best to find a clinic with experience so that they're able to explain, the process. There have been questions about whether or not through the PGT it's possible that there could be some accidental disclosures. So it depends on how the laboratory that is doing the PGT testing, how exactly they're doing the genetic testing, and whether actually doing the DNA test to look for expansion is part of their process. So if that is the case, then in theory, there's some question about whether or not there could be some accidental disclosure. But I've spoken to a number of clinics that do non-disclosure PGT and have said that they haven't had so far any cases where there's been an accidental disclosure, because everyone is being very careful to try to make sure that does not happen. The thing to keep in mind about the non-disclosure option is that if in the future the person does find out that they did not inherit HD, then they may have some regrets about everything that they had done to go through the non-disclosure process. So they may think, I did all of this and it wasn't necessary. In the prenatal option, they may have stopped pregnancies that actually were not affected with HD now that they know they didn't inherit HD. And in the PGT process, they didn't use embryos because it was presumed they could have HD, but actually now that the person has tested negative, they know that those embryos were normal. So it is something to really think about, even though it's, the advantage is if the person really doesn't want to know their status and the distress that may come from feeling pressured to find out their HD status, but it can, as in the future, also have some complication as far as regret or second guessing kind of choices that they made. So that is the summary. I think that's my last slide. So we were going to open it up for questions, and I think we'll hand over to Sarah. Thank you.
Thank you so much, Claire and Susan. That was a lot of information, very interesting. And so if anybody does have questions, they can enter them in the questions tab on the right-hand side of the screen. And I'm going to get us started with a question for either one of you in terms of, if somebody's interested in getting tested, what would be the next steps for predictive genetic testing?
So for most people, most clinics require a referral from a family doctor. Some clinics will allow self-referral because we know that there have been family doctors that have said, oh, they've been against their patients having predictive testing. So there are some clinics that will accept self-referrals. But generally speaking, it's a referral to a medical genetics clinic that has a predictive genetic testing program.
Great, thank you. And then just as a follow-up to that, I know we chatted a little bit about the steps once the referral goes in. They would receive a call, and then is there typically a bit of a wait list or wait time?
Again, it really varies from clinic to clinic. On average, it's usually a few months, but there are some clinics that are backlogged, and so it would be something that you could try and find out ahead of time. And I know most clinics certainly have a way of, if there's a reason for that person to be seen sooner rather than later, then that's important information for the referring doctor to let the clinic know.
Wonderful, thank you. Claire, similarly for the PGTM or the other steps, what would be, if somebody's interested in that, what would be their next steps to start looking into that process?
Right. So they can start by talking, if they've already gone through testing or had some interaction with the genetics clinic, they can reach out to their genetic counselor, who could provide some more information to them about, especially kind of what's specific locally. But if they're really interested or thinking quite seriously about the PGT, it's best probably to be referred to the clinic, the actual fertility clinics that do it, because they can get into much more detail, be much more specific about the costs involved, which laboratories they're using. So I kind of alluded to the fact that it depends on which laboratory they're using, how the test is specifically done. The actual genetic part of the testing is done. So I think that usually the fertility clinics are quite happy to have those consultations. So I would encourage the person to reach out to their genetic counselor, as well as find a local clinic that has some experience.
Wonderful, thank you. Just another question that I think comes up often in my line of work when working with families is around, and Susan, maybe you can answer this as well, if somebody goes through the predictive testing process and then before they receive their results, they change their mind and they'd say that maybe they're not quite ready to receive their results. Is that okay? And how long do the test results stay on file if they do?
Forever. So one of the things I didn't mention that I meant to was that one of the holdovers, for, at least in Ontario, from the original predictive program was that the results come sealed. So we don't know the results at the point that we contact the patient to say, your results are in, would you like to make a results appointment? And then as part of the counseling process, we say to people, you may not be ready for your results, or something may have happened between the time you went for the blood work and the results have come back, and they can stay sealed in your chart forever, right? So because genetic results don't change or alter, we in genetics keep medical records permanently. And I've had patients come back 3 years later for their results. I had one woman who said, I don't want to know my results, but I want to have the testing done and keep it sealed in my chart so that if I die before I would develop Huntington's, my children can have access to that information. So we can't speed up the process for people, but we can always slow it down. And that's one of the ways that if people aren't ready for testing, then we want them to determine when they're ready for those results.
And just as a follow-up, the one thing, I've had people say that they want to do it so it's ready, so that as soon as they're ready to get them, they can just zoom in and get their result. And I did want to just, at least how we do it at North York, is that if it's been a few months, then the process as far as the number of contacts would be the same. They could call up and we would book a results appointment. But if it's been like 2 or 3 years, we'll probably do kind of like an update session just to make sure that we have kind of the up-to-date information about how that person has been doing in the past 2 to 3 years, and then book the results session. So just to know that each clinic may be a little bit different. It wouldn't be just the person could call up at 3 years later and say, oh, tomorrow let's do a results session. Like there may be some process that we would go through. And it's all really just about, supporting the person properly, having all the safety nets there, us kind of knowing the situation so that we can be the best support to that person. And in 3 years, a lot can change. So that's why we would do the update and just make sure we kind of knew what has been going on and what brought them to the decision to be ready to go ahead with their results.
I think that's really important information to share, as you spoke to, in terms of this is life-altering information one way or the other. So I think that's wonderful to make sure that people know that we want to make sure that they are supported and that they have what they need in place before they receive the results. So that's great. There is a question that came in, and the question is, in relation to testing positive and the likely need for follow-up and support, would referrals be made to a Huntington Society social worker? Does that come from genetics?
So I co-counsel with the Huntington Society social workers. So we've already got that support in place, and that's been a really important addition to our predictive genetic testing program, because it's one thing to hand somebody a card or a phone number, which seems very impersonal. And it's another thing when they've actually met that social worker, at least even if it's only virtually, they know the name, they know the person. And so that's a really easy link for us, but not every clinic has the luxury of having a Huntington social worker, but very much so we encourage people that they might want to even be referred to a neurologist, depending on their age, just for a baseline assessment and just to get into the system. And that's the best way often to find out about research trials and other things that are happening. So there are many different, every clinic is a little bit different, but yes, for sure. It's important that people aren't just sort of sent out back into the community without any kind of support.
Right. And Claire, does your clinic operate similarly?
Yeah, so we don't have the HD social worker be a part of all of our predictive results. But what we do is provide the information. What we try to do is encourage anyone who tested positive to have a neurologist, and we have a psychiatrist as well if the person's having some adjustment issues or kind of wants to talk to a psychiatrist. So we do encourage that kind of next steps, and we'll also offer to connect with the HD social worker. The interesting thing for our perspective at North York is that we have such a huge geographic kind of catchment area that we work with like 4 different social workers, and I am trying to always keep track of where your regions and who is doing certain regions. So that does end up being a little bit a part of the challenge. And so, but as a need comes up, we do encourage them to reach out to the Huntington social worker, because we do find that is a very very helpful resource and just another way of supporting people through this process.
Yeah, that collaboration I think is so important, and to help provide that kind of seamless support for individuals. So that's wonderful.
Well, and also with younger people, we also kind of strongly encourage people to get involved with the mentoring program. And with the Huntington Society, because I think that's huge, for families, younger people when they've gotten these kind of test results.
Yeah, so that's the youth mentorship program that you're mentioning, Susan. Wonderful. That's great. So just looking at the time, so I thank you so much for that informative and engaging presentation and answering the questions. We're very grateful to both of you for being with us today. That's all we have time for right now. But there's lots more other programming to come in the other sessions. So anybody that's in the audience, you can now head out to the main lobby and join your next session. And thank you again, Claire and Susan, for joining us.
Thank you for having us and inviting us. Always happy to share information with everyone.
Wonderful. Thank you.